Good evening. My name is Janine Salente, and I'm the Executive Director at the Diabetes Foundation. Welcome to Diabetes Care Month, a four-part series dedicated to breaking down the barriers of self-care that you may be experiencing. Today, we'll be discussing diabetes myths versus reality. This topic was chosen with great purpose. There is a lot of information on the internet about diabetes and diabetes self-care. Knowing the realities of diabetes versus the myths will ensure that your efforts for self-care can lead to your very best health. At the Diabetes Foundation, we know that the most manageable diabetes is yours. If you know what to do, where to find support, and are encouraged to follow through. Our programs offer the guidance, education, and support that can help you achieve all of your goals. My hope and that of our trustees is that our session today will inspire you to contact us on behalf of yourself, a family member, a friend, or a patient for help with their self-care. Before I turn the session over to our moderator, Dr. Stephen Gani, I encourage you to utilize the Q&A function at the bottom of your screen to ask questions. We will address as many as we can tonight and following up with answers to the remaining questions by email in the coming days. I also want to take a moment to thank our Diabetes Care Month sponsors for all of your help and your great generosity. Because of you, we're able to provide all of our services to the public for free. Thank you to BD, Essentia, M&T Bank, the Russell Berry Foundation, Healthcare Foundation for New Jersey, Horizon Foundation for New Jersey, Sanofi, BioReference, George Link Charitable Trust, the Association of Diabetes Care and Education Specialists, Bergen Newbridge Medical Center, Wegmans, Nanette Empney Bryan Foundation, and the S. Rubenstein Family Foundation. As I mentioned earlier, Dr. Stephen Gani is our moderator for tonight's session. Dr. Gani is board certified in pediatrics and pediatric endocrinology by the American Board of Pediatrics, receiving his education and completing his residency and his internship in pediatrics at Rutgers, New Jersey Medical School, and his fellowship in pediatric endocrinology at SUNY Downstate Medical Center. Dr. Gani is currently a pediatric endocrinologist with the Molly Diabetes Education and Management Center for Adults and Children at Hackensack University Medical Center. He is a member of the Diabetes Foundation's Board of Trustees and a member of our executive committee. And I want to thank you, Dr. Gani, for leading us in tonight's session, and I'm officially handing over the session to you.
Thank you, Janine. It's an absolute pleasure to be here, and thank you for the invitation to host tonight's event. Diabetes is definitely the epidemic that will live on way past COVID-19. For many across New Jersey and the nation who live with diabetes, the condition affects life for them each and every day. Change is always a word that you hear often when you're diagnosed with diabetes, but your lifestyle and diabetes care, as well as self-management, may not be so far apart. Even in this challenging time with the global pandemic, it is possible and well within your reach to take good care of your diabetes. From eating healthy to medication monitoring, today's session will help provide the participants with an accurate representation of what it means to be living with diabetes today and how you can effectively live your life without major interruptions from diabetes complications. Tonight, we're gifted to have important players from our community to speak on the importance of healthy living, as well as the importance of a healthy lifestyle for those who may be living with diabetes. Tonight, you will learn about easy pathways for better healthy and diabetes outcomes. Before we get to our first speaker, we're going to launch our first poll for today. There's going to be two polls in our session. And the first one is a true or false question. So true or false, sugar is a carbohydrate. We ask our audience to answer the poll as it pops up on their screen. We'll leave this poll open for several minutes and we'll share the results toward the end of the program near the Q&A session. Okay, it's my pleasure to introduce our first speaker today. Our first speaker is Hilda Hernandez Sepulveda. Hilda is a registered nurse with over 28 years of clinical experience in Puerto Rico, New York, and New Jersey. The majority of her focus has been on hemodialysis and diabetes management. She is a diabetes program coordinator for the Diabetes Center at Holy Name Medical Center in Teaneck, New Jersey. Hilda is responsible for the daily operation of the inpatient and outpatient diabetes self-management education support program, where quality patient care, empowerment, and education are the top priority. Certified by the American Diabetes Association, the Diabetes Center at Holy Name Medical Center provides programs and counseling that reflect the highest standard of education for patients about behavior change, self-management, as well as prevention and care during diabetes complications. Patients at the center receive counseling from a registered nurse and or a registered dietitian who are also all certified diabetes educators on insulin self-administration, blood sugar monitoring, exercise, health maintenance, as well as the importance of routine physical follow-up, insulin pump therapy, and continuous glucose monitoring. Without further delay, it's my pleasure to introduce Hilda Hernandez Sepulveda.
Thank you so much for that great introduction, Dr. Gani. I want to take the opportunity to thank the Diabetes Foundation for providing this opportunity for me to talk about carbohydrate intake with diabetes myth versus reality. Um, Diabetes is a chronic disease that reach epidemic proportions worldwide. And uncontrolled diabetes has many serious consequences. Therefore, eating certain foods can raise your blood sugar more than others. Carbs, proteins, and fats are the macronutrients that provide your body with energy. Among them, carbs have the greatest effect on your blood sugar by far. That's why we're going to be talking about carbohydrates, the facts and the myths. So, some important information or facts about carbohydrates: they're not all created equally. Um, Think about carbs as your raw material that powers your body. It provides basically energy as your main source of energy. Um, they come in two types: simple and complex carbohydrates. Some of the complex carbohydrates that you can think about, I mean, sweet potatoes, brown rice, oats, fruits, um, beans, those fall into your complex carbohydrates. Some of the simple carbohydrates that come to mind can be soda, candy, uh, baked goods, anything that's pretty much made with white flour will fall into that simple carbohydrate group. Next. A little closer look at carbohydrates. Simple carbs, they break down quickly into sugar. We usually say 100% sugar within the first 15 minutes of ingestion. It may have a greater impact on your blood sugar. So that's one of the reasons that a lot of people feel like, we shouldn't be eating carbs and carbs are dangerous or your enemy. Um, you might want to eat less of these simple carbs because of the effect on your blood sugar. You find them easily in table sugar and syrups and some of the other ones that I just mentioned. Complex carbohydrates, they're packed with more nutrients than a simple carb. They are high in fiber, therefore they digest slowly. We encourage you to eat more of the complex carbs versus the simple ones. And they are usually a better choice and also keep you fuller because of that fiber component that it has in the food. Next. Next. So carbohydrates can be an important part of a healthy, well-balanced diet, one that you can stick for a long haul. When choosing carbohydrates, avoid processed carbs and opt for healthier carbohydrates like vegetables, fruits, whole grains. They're high in vitamins, minerals, fiber. They keep you satisfied and feeling great for a longer period of time. We usually recommend when carbohydrates are in to have like a protein source with it or a healthy fat. It keeps you fuller and it gives you that satiety for a little longer period of time. It also diminishes the amount of like sugar, like the spike of the sugar so quickly when you combine them with a protein and a fat. Next. So the big question is, can people with diabetes eat carbohydrates? That's always the big question when patients come into our office. They're always saying, oh, my doctor or my dietitian or my family, they say that I cannot have carbohydrates, that I shouldn't eat fruits, that I shouldn't eat pasta, that I have to stay away from rice. So then the question is, what do I eat, right? So of course we encourage patients that, they should have a balanced diet. But people with diabetes certainly do need to manage their diets carefully. Monitoring carbohydrate intake is important because of the impact or the effect on the blood sugars. However, you can still incorporate those treats into special occasions. According to the ADA, the key to sweets is to have a very small portion and save them for special occasions. So focus your meals on healthier foods. So I always say we all have a birthday, and I would not like to tell anyone you cannot have a slice of cake on your birthday. So it's about moderation and about how and when to eat them. Individuals with diabetes need to carefully plan what and when they will eat to ensure that their blood sugars levels remain balanced. Um, Also, I mean, if you're eating carbohydrates and your doctor has prescribed medications, matching those medications with your meals are very appropriate and important. Next. So I just wanted to touch up on, I didn't realize this was my last slide, but some of the other points that I would like to bring up is that carbs can definitely be incorporated into your meals and snacks. Of course, always trying to select something that is a better choice. So for instance, if you're having a juice versus a fruit, it's better to have a piece of fruit. It digests a little bit slower because of the fiber. If you're have to select between white rice and brown rice would probably be more nutrient dense, so it's a better choice. The other thing is portion control. It's going to help you maintain your blood sugars from spiking so much. Learning how to read a food label, it's going to give you that information that you need about those carbohydrates, and in terms of like what's the appropriate amount that you should be eating, the portion, how much sugar added, table sugar. With the new food label, you can see that on that food label. Using measuring cups is also going to allow you to understand what's the serving, how much am I eating, can I cut down on the amount of carbohydrate that I'm consuming in that particular meal. The plate method, I strongly encourage most of my patients to look at that plate method, using half of your plate with vegetables, a quarter will be your protein intake, and then the other quarter will be your carbohydrates. Lastly, I encourage uh, every patient to meet with a certified diabetes care and education specialist. They will individualize the care and your meals to your needs and your liking. And the bottom line is that it is a myth about carbohydrate being unhealthy. It's just making the better choices and looking at what other alternatives you have and maintaining the portion control. The truth is that some of the world's healthiest foods are high in carbohydrates, although they should not be eaten in large amounts. Thank you.
Thank you, Hilda, for that great presentation. Diet is such an integral part of diabetes care, so we really thank you for that great presentation. So our next speaker I'd like to introduce is Brian Herrick. Brian joined the Juvenile Diabetes Research Foundation International, JDRF, in 2010 as a member of the New York City chapter. In 2013, he moved to the JDRF's National, where he currently serves as Senior Manager, Research Communications in the Research Department. His work primarily involves communicating JDRF's research strategy and advances to internal and external audiences. Brian himself has been living with type 1 diabetes since 1993. Since 2014, he has participated in several JDRF and SDP funded clinical trials. testing out the artificial pancreas technologies a lot of us have heard about, as well as implantable sensors that also a lot of our participants may be reading about. He has been a study participant himself, what we call the guinea pig, for several other therapies and research experiments. He has spoken on behalf of the JDRF in U.S. News and World Report, CBS, Fox News, and many other media outlets. So Brian, welcome, and thank you again for giving this great presentation.
Thank you so much for having me. I feel terribly underqualified to give this presentation, given the guests that are on the panel, the doctors and nurses. So I'm really happy to be here. As I said, I've been living with type 1 for almost 30 years. And I'm here to talk a little bit about the differences between type 1 diabetes and type 2 diabetes. They're both on the rise in the country and in the world. They're both something that requires more, public health awareness and public funds and attention. So I just want to talk a little bit about type 1 itself, and then the differences between type 1 and type 2. And I will say that while these are technically different diseases, they have a lot in common. They manifest very similarly, and a lot of the treatments that we have for type 1 are also applicable to people with type 1. Anyone that is insulin dependent or uses continuous glucose monitors, those are stuff that people with type 1 use all the time. I'm wearing my Dexcom CGM in my arm right now, and I have my insulin pump in my pocket. So a little bit about type 1 diabetes. We call it T1D at JDRF, we like to abbreviate everything. So type 1 is an autoimmune disease, and what that means is you have insulin-producing beta cells that live in the pancreas that the body, for reasons we don't fully understand, but we're trying to fully figure out, are attacked by the immune system, and they are destroyed, which renders someone with type 1 insulin dependent for the rest of their life. Hopefully that won't be the case forever, but right now we don't have a cure. So people with type 1 have to rely on insulin pumps, take injections. There are many ways to do it. We don't really also know why type 1 happens. There's a lot of indicators that there's environmental factors. There is certainly a genetic predisposition. People that have type 1 and then have kids, their kids are at a largely increased risk of developing it. But it can happen at any age. We used to be called the Juvenile Diabetes Research Foundation, and we have since condensed that to JDRF because while it certainly does affect a lot of kids and a lot of youth, people who are diagnosed when they're young, they never grow out of it. This isn't something that you're afflicted with as a juvenile, and then it goes away as you get older. People have it for life. And also, many people are diagnosed with type 1 as adults. Often they are misdiagnosed with type 1 with physicians, thinking that it's type 2. So it's our job to get out there and make sure that people know more about type 1 and know that it does affect, almost 2 million Americans and millions more around the world. The other thing about type 1 that's important to know is there's currently no cure for it. I wish there was, that would be nice. And there's also no way to prevent it. We can identify through certain blood tests who's at risk for developing it, which is a huge step. And in the near future, we're going to have what we call disease-modifying therapies that can hopefully prevent the development of type 1, delay it once it starts in those folks that are at risk. But those aren't FDA available yet. They do not currently exist. And there's nothing really we can do for people that are going to develop type 1. There's something we can do to stop it. I mentioned before, it happens to kids and adults at any age. I was diagnosed when I was 3. I'm having my 30th diabetes anniversary next year. Maybe I'll have a party. But it happens to adults too. I know people that have been diagnosed in their 50s and their 60s. And then I mentioned people with T1D rely on insulin therapies to control their blood sugar levels. And for me, it looks like an insulin pump. I got it here in my pocket, right here. It's hooked up to a tube, which goes into a little cannula in my body, and then I change it every 3 days. And it's great technology, but it'd be nice if I didn't have to wear it. Can you go to the next slide, please? Okay, so some myths versus facts. I want to talk about the differences between type 1 diabetes and type 2 diabetes. So the reason they're both called diabetes is because they manifest in very similar ways. It's very high blood sugars. That's the trademark diagnosing factor for type 1 and type 2. However, the majority of people do have type 2, not type 1. Type 1 is about 5 to 10% of the population, and type 2 is 90 to 95%. And again, type 1 and type 2 are both on the rise, especially type 1 and especially in Western societies, but it does happen all over the world. But the incidence of it is rapidly increasing as time goes on, and it'd be great if we could figure out why. Type 1, my body does not make any insulin or makes a negligible amount. People with type 2, their bodies still produce insulin, which is great. It just doesn't quite, it's not as effective. It doesn't get absorbed as well, or the body can't make quite enough. But type 1, no insulin production. Type 2, people are insulin resistant. The mechanism behind these diseases is very different as well. So type 1, as I mentioned, my body attacked itself. The immune system was overactive. It destroyed the beta cells, which make the insulin. And the beta cells also are not really in great shape to begin with. They're stressed in a lot of people, and so they're kind of hardwired to break, essentially. And type 2, on the other hand, is metabolic. So the cells, these beta cells that make insulin, are still there, but the insulin just doesn't work as effectively as it once did. Type 1 and type 2 are both tied to genetic susceptibility. People with type 2, very often it's a thing that is hereditary. It's a thing that is in their DNA. Type 1 is a similar thing. It certainly, people can be more predisposed to it depending on different family relations, people that have type 1. But type 2 is also tied to metabolism. So again, it's people with type 1 and type 2. There are many factors that contribute to it. It's not one thing you can point to and say that's why this disease developed. And the last thing I'll mention is type 1, again, not preventable without insulin, and type 1 diabetes without insulin therapy is fatal. Type 2 diabetes, you have a few more options. It can be prevented or delayed through diet and exercise. Certainly that's not going to work for everybody. But these diseases do manifest themselves a little differently. Both are certainly an enormous challenge to live with. The tools we have to live with them today are nowhere near perfect, but they are getting better. And actually right now we're working on getting a lot of the drugs for type 2, like the Ozempic and other SGLT inhibitors and such, approved for type 1. So there's a lot of crossover between these two diseases and the different drug therapies that we use to treat them. So I think that's all I have for my type 1 and type 2 facts and fiction. So I'm happy to pass it on to the next presenter and address any questions we have in the Q&A.
Great. Thank you, Brian, for your great presentation, your insight into diabetes. So before we get to our final speaker of the evening, we would like to launch our second poll, and this one's a little bit more challenging. So this question asks, according to the American Diabetes Association, the Association of Diabetes Care and Education Specialists, there are how many care tools involved in comprehensive diabetes management? All right. We ask our audience to answer the poll when it pops up on their screen. We'll leave the poll open for a minute or two, and we'll share the results of the polls following the Q&A portion of today's program. Again, if you have any question and answer, please put it in the Q&A section tab on the bottom of your screen. All right, so I would like to introduce our next speaker. Our next speaker is Christopher Bryant. Chris is an active Diabetes Foundation participant and career IT professional, was diagnosed with type 1 diabetes at the age of 16. For 30 plus years, he has seen the ups and downs of living with diabetes every day. He experienced common complications of the condition, including eye retinopathy, as well as kidney disease. He unfortunately suffered end-stage renal disease, commonly referred to as ESRD, and was blessed with a second chance by way of a life-saving kidney transplant. He now has a new outlook on managing diabetes and has mentored others with similar situations, all with the focus of helping others understand the importance of taking control of their diabetes care. Chris, thank you for joining us today and providing your insight through your personal experience. Again, I'd like to introduce Chris.
Hey, thanks for having me. I want to take this opportunity to thank the Diabetes Foundation and, of course, JDRF. They helped me with the research to get the knowledge on how to care for my diabetes for many years from before. So, yes, I was 16 years old and I was diagnosed with type 1 diabetes. Now, you have to think about, I'm a teenager in high school, and all of a sudden I used to run track. I was a thin kid, and all of a sudden I'm telling my coach I need a bathroom break, I need a water break, I need a bathroom break, water break, until I figured out something must be wrong. I need to go to the doctor, and they diagnosed me with type 1 diabetes. That was a tough time because the whole world was flipped upside down. I was used to eating the foods that I ate, drinking the foods, hanging out with my friends, doing the things, not having a care in the world, and then it had come to a abrupt stop where now I have to give myself insulin, change my diet, and everything, and go to doctors and all this kind of thing that would just change everything completely. So at a young age, when the truth is, you really don't, when you got diabetes, you really don't feel the problems of diabetes, when you have a high sugar. Yes, you may have frequent urination, you may have increased thirst, you may even feel some fatigue, uh, you may have some blurry vision, but for the most part, you can get around and do the things that you need to do. Of course, when you go low, you feel lousy. I don't even want to think about that. But for the most part, if it's at normal level, it goes up to 150, 200, 250, maybe even 300, you can feel fine and get through your day. So this is me as a kid at 16 years old, not thinking about the risk that came along with having diabetes, right? I didn't, like any other kid out there, you see what they do out there. They say, well, that's a risky thing they're doing. You don't realize that until you get older, and then you see what happened down the line from doing those risky things. So basically, I wasn't controlling my diabetes. My sugars were out of control. I took some insulin when I wanted to take insulin. I still hung out with my friends. I still did all the things, not thinking about what's coming on down the line, with all the issues, right? So it's not until I reached about, I want to say 26, 27, I get a little bit more maturity. I get married, and my wife wasn't trying to hear that in terms of me not taking care of my diabetes. So what do? I start to build a diabetes team. Up until this point, all I had was the primary care doctor. I would show up, check my sugar, write me a script, give me some syringes, some insulin, and then I'm on my way until the next visit. Once I started to build a team, the first person I got, one of the most important people when it comes to diabetes, is an endocrinologist. So I get this endocrinologist, I start to go, and then I start to build my team from there. It's a funny story how when I started to go to my endocrinologist, my sugars was through the roof. My A1Cs was through the roof. And we figured out a way on how, based on my lifestyle, to get it back down to normal numbers. So my doctor would pull out the file and ask me these questions. She says, do you go to a podiatrist? Do you go to an ophthalmologist? And I would always say, no, that's all right. I'll get around to it. I can see well, my feet look good. And then the next appointment, the same thing. Have you seen a podiatrist? Have you seen an ophthalmologist? I don't know. No, I didn't see that. The third visit, she actually called the podiatrist, called an ophthalmologist to make an appointment for me. And as a motherly doctor she was a bit older than me. She would say, Chris, don't come back to this office until you go to those doctors. So what I do, I go to these doctors. And the ophthalmologist, as I can see pretty good, I didn't need glasses or anything, he saw bleeding in my eye. Complication number one, boom. It was like a punch in the gut. I needed to have retinopathy surgery. My eye was bleeding. The retina was still attached, but I still needed to do some eye surgery in order to continue to have my vision that I have. That's strike one. Then I continue. A few years later, I go to the endocrinologist and I find out that my creatinine is increasing. Now, what's creatinine? I don't know what creatinine is. I find out, it turns out that I'm facing ESRD, or end-stage renal disease. So what does that mean? In short, it means that I'm going to have to start dialysis. Complication number two, boom, a wake-up call to me. Fortunately, out of nowhere, and this is a story in itself, that I was able to get a kidney transplant. 5 months later, from a living donor, a person that I didn't know, who decided that they wanted to give a kidney to a person like me. So I get this kidney, and boom, that was the last thing that I needed to know, that I had to take care of my diabetes. I had a second chance at life. And this is the time that I need to take it seriously in order to get all of my sugars under control, continue to build my team, because I don't want to have to go back on dialysis anytime soon. Next slide, please. Okay, so this is what happens after I get my transplant. I'm feeling good, I'm back to work, but I realized that diabetes is real. If all of those 10 years back in the past when I wasn't controlling it, now I'm feeling the effects of it. So it's imperative for new diabetics out there to say, listen, I need to control this from day one of diagnosis. So what did I started to do? Some of the things that I did is I started to exercise more. Now, I wasn't like not exercising, but I increased my exercise because I knew it was better for me. Also, another thing I did was I changed my diet. My diet was out of control. I would eat pizza, cake, cookies, and I would try to count the carbohydrates, and I would take the insulin based on the carbohydrates. It never worked. I needed to change things to eat complex carbs in order to get the best control of my diabetes. Finger sticks. I would monitor my sugars more closely and under 10 times a day, sometimes 12 times a day, in order to know what my sugars were. Remember, more information is better. So I would check it in the morning, before and after each meal, before bed. If ever I don't feel well, I would check it even more than that because I need to know what my sugars are to gauge what I need to do from this point forward. You have to become an expert of your own diabetes. There's a lot of sites out there. Some of the stuff tells you myths, some of the stuff is reality. You can go to sites like the Diabetes Foundation. JDRF is awesome. And this way you could be knowledgeable rather than just telling a doctor telling you what to do. You have an idea of what's happening to your body in terms of diabetes. So one of the things I've also learned how to do was count carbohydrates, really count carbohydrates. It takes a little work and you have to remember certain things. How many carbohydrates in a slice of bread? How much carbohydrates are in this food or that food? Now we have this technology around me and I could just say for the Google, how many carbohydrates is in XYZ? I don't want to say the other words because I have one here. I don't want it to go off, but I can say how many carbohydrates are in 4 ounces of rice and it would tell you. And based on that, I can know exactly how much sugar I am. It's just another thing to become an expert and taking control of your diabetes. Family support. There's nothing greater than family support. Friends, family, close ones, loved ones, relatives, it all matters. It's a big part in controlling your diabetes. I can get up and go out for a run with somebody that has diabetes. Get them out the house, motivate them. You could change your diet within the house. You can go to doctors with family members. It doesn't matter. Any kind of family support in order to control your sugar is better. The more support, the better. Next slide. Now, my tips, after I've been through it there and back, it doesn't matter. I had the kidney transplants because the first one has been since rejected. I went back on dialysis, this time for 2.5 years until I had another kidney transplant back in 2018. I'm doing well now, but I had to go through the difficult times to get where I am now. Have a positive attitude. So no one knows your body better than yourself, right? When you don't feel well, something's wrong, you will know it. And when you know it, then you should go to the doctor and write it off if it's something related to your diabetes. For example, I take a new medication. I don't really feel well. I feel tired. I can say, oh, maybe because I need to lose weight, or maybe I need to get more exercise, or maybe I'm just getting older and this is how it's supposed to be. Well, if you go to the doctor, then you can mention these concerns that you have. You could be tested for these and see and write off or rule out whatever that can be causing you. So you know yourself, when you don't feel right, chances are that there may be something wrong. The team that you build, the diabetes care team, is imperative to controlling your diabetes. I can't stress it enough. So we always start with my favorite doctor is the endocrinologist, right? You also have to check your feet. We know that when it comes to diabetes that you need a podiatrist. Check your feet regularly. An ophthalmologist. You don't know what's going on there in the back of your eye. It's better to go for checkups than to go after there's a problem. A diabetic educator. Learn about the new technology and the new treatments out there that comes when it comes to caring for your diabetes. And a nutritionist. A nutritionist can teach you how to count these carbs and the better foods to eat, the foods that break down faster, metabolize quicker. A nutritionist has all of that. And hopefully you never have to reach this point, but a cardiologist. A cardiologist to check your heart, because we don't want this diabetes to start affecting your heart. Have a stress test maybe, who knows? but a cardiologist should be part of your diabetes team. Diabetes is a 24-hour illness. It's not like you take a pill or take an injection and you can forget about it. No, I'm sure that other type 1s and type 2s think about diabetes all day long. You figure out you're counting times, 20 minutes before you could take a bite, you're counting carbs, you're doing all kinds of things. It's all going back to thinking about diabetes 24 hours a day. Even when you wake up in the middle of the night, you're still thinking about your diabetes. And because of this, it can be stressful. But I'm asking you, as a diabetic for more than 30 years, that you have to believe and think positive. I have a positive spirit. So no matter what happens and all that I've been through, a positive outlook is why I'm here today, right? So you try. It can be difficult, and I'm with you there. I know it's very difficult, but to think positive and say, listen, I'm going to get through this. I'm going to grab this diabetes by the horn, and I'm going to control it, right? I can hear the people that I talk to all the time that say, Chris, I got diabetes. I had it for 6 months or a year, and I'm having a hard time controlling this thing. I'm having a hard time keeping my sugars under control. I can say, I hear you. I'm with you. Or I can hear the diabetic that says, I haven't been controlling my sugars and that I'm now on dialysis or I'm having problems with my heart. I can say, I'm with you. I hear you. But hopefully I can hear you say to me, Chris, I got my sugars under control. I'm eating a healthy diet. I got a nice exercise regimen and my A1C is within range. Then I can say, I'm with you. I hear you, because you may have diabetes, but diabetes does not have you. And I'm going to pass this back to Dr. Ghani. And thanks for everything.
Thank you, Chris, for that great presentation and for your personal journey down your life with diabetes. I think all our participants here with diabetes really identify with your story. And I think the tips that you gave was really great and really integral for great diabetes care. So thank you very much for that. So with the time we have left, our panel is happy to take questions. Please submit your questions via the Q&A function at the bottom of your screen if you haven't done so already. We'll try to get to as many questions as possible by our panel, but we'll also provide written responses in the next coming days. All right, so I'm going to open up the Q&A section now, and I'll read off the questions, and I'll invite our panelists to come back in, and feel free for any of the panelists to answer the questions. Okay, so our first question says, how would high, it says VS, low glycemic index foods would eventually affect your diabetes management? Any of our panelists want to answer the question?
Hi, I'm going to comment on that, even though I'm not a nutritionist and we try not to focus so much on the glycemic index. Instead, we look at the total carbohydrates, but there are foods based on the glycemic index that break down faster into sugar. So when you're looking at some fruits, some of the foods that can actually impact your blood sugars higher, you want to probably look at those that with a lower glycemic index, high fiber, which are going to have a less of an impact on your sugars. But again, you start looking at glycemic index, it's going to be very time consuming. So it's something that you could probably discuss with a dietitian to give you a list of those foods that are higher and lower. But it's something that, you can definitely focus if you like.
And Hilda, a follow-up question to that along the same lines is, how much carbohydrate do you recommend per day? And what is a general formula to stagger in the entire day?
Yeah, so usually what we do is we try to recommend about, for women, about 45 grams per meal, and men about 60. It really depends. Again, this is very individualized. This is not a cookie cutter. 45 to 65% of your total daily calorie intake should be about of carbohydrates. Again, very individualized. What works for one person might not work for another. But the standard recommendation is about 45 grams for women for breakfast, lunch, and dinner. And if you're going to add a snack, 15 to 25. and the same for men, about 45 to 60 per meal, and then snacks between 15 and 20. Um, no more than 2 snacks a day we try to recommend. So in total, about totals about 100 and maybe 50 to 75 grams of carbohydrates a day.
I have a question here. Someone on the presentation, I'm not sure which presentation this came from. It says, what do the numbers refer to? Question mark 110, 200, etc. These were blood sugar levels, or
It could be blood sugar levels,
I'm
but
thinking, yeah. Okay. Let me see here. I have, does pre-diabetes always lead to full-fledged diabetes? Anyone want to take that question?
I'm going to comment on that. Pre-diabetes is a precursor for diabetes. It doesn't necessarily always have to end up in diabetes. That's why we encourage our population of patients to look into lifestyle changes, uh, uh, meal plan, exercise. Um, if you do the right things and you target those recommendations, I mean, you shouldn't have to really convert to type 2 diabetic.
Okay. Question, what is the optimal A1C for non-diabetics wanting to stay that way?
Can you repeat the question, Doc?
Sure. What is the optimal A1C for non-diabetics wanting to stay that way?
We recommend less than 6. Well, optimal will be less than 5.7, which is normal.
Mhm.
Diabetics, I mean, usually, again, very individualized. Someone with diabetes that have multiple comorbidities, we might recommend 7.5, 7, 8. I mean, it really depends.
Great.
And type 1, the recommendation is usually below 7 for someone that already has type 1.
Sure. Okay, this question is for Chris. Can you describe hi Chris, can you describe the exercise that you do to keep your body active? How do you fit it into your life, as I'm sure you are busy?
Well, one of the things is I got me a Fitbit. I do some steps out there and kind of walk around the apartment. During this COVID time, it was a little bit different. You know, I would have to walk around the apartment, but I would still find times when there aren't people around to wear my mask and continue to walk outside. Now I made my first attempts to going back to the gym on off-peak times. So I just try to stay active, and hopefully I can get out and do some more running.
If I can add on to that just for 1 second,
Sure.
You just have to find a way to incorporate it in your life. Chris, I don't know if you feel the same way, but like when I exercise, like it helps with type 1. Like if my blood sugar is high, rather than correcting that with insulin, I can take a walk and it will almost always knock it down.
Exactly.
It takes a little extra planning to make sure that you have things in case you get low in your run or that sort of thing, but exercise is the cure to a whole lot of things. And when you're living with type 1 diabetes, it's the most important thing, one of the most important things, I think, in achieving what we call like optimal, outcomes, blood sugars and A1Cs where you want them to be. And it's a huge help.
Exactly. Yeah, I agree with that. It's like, I don't know if it's something to do with the insulin absorption or something like that, but when I'm moving like that, then I find out that I need less insulin, especially basal insulin, while I'm working out there. So yeah, I do agree with that. Yeah.
All right, great. Next question says, are there good proteins to gravitate toward and other proteins to avoid?
I usually recommend, the good proteins, almond butter, nuts, peanut butter, eggs are great choice as a great source. Cheese, I mean, if you look into, low fat cheese, um, lean protein, I mean, like chicken, beef, fish, beef at least once a week, no more than that. But those are good sources of protein. And the bad ones, I mean, I would say maybe just try to refrain from eating so much red meat as a protein source, maybe once a week or twice, no more than that, because of the high cholesterol.
Right. Great. Thanks, Hilda. Next question asks, I'm having diabetes for the last 35 plus years. I take insulin thrice using Dexcom 6. I've never gone to an endocrinologist and have not consulted diabetes educator. I have question. Number one, how can I consult them? Number two, how can I know whether my pancreas is working or not, producing insulin or not?
Um, if you have diabetes for over 35 years, definitely I encourage you, and I'm sure that Christopher and Brian also mentioned that, seeing an endocrinologist, I mean, besides your primary doctor, is important. As I always say, if you have a heart issue, you want to see a cardiologist, and if you have metabolic or endocrinology problems, you want to see an endocrinologist to help you with a better understanding in terms of medication. With regards to a diabetes educator, you can actually go on the ADA or the Diabetes Association of Care and Education Specialists website, and you can find local programs if you put the zip code. Normally what you need is a prescription from your doctor saying that, you're referring you to a diabetes educator for a consult and schedule an appointment.
Great. Thanks, Hilda. All right, last question I have here is, how long do you have to maintain range glucose levels and A1C, effective weight loss, to be classified in remission?
I'm going to comment on that as well. You hear that a lot, that some patients are type 2 and then their levels remain, they go back to normal range and they feel that they're not diabetics at this point. I disagree on that. If you're a diabetic, you're a diabetic for the rest of your life. You manage it with your portion controls, lifestyle, and the fact that you feel like you're in remission, like things are okay, does not mean that you're not a diabetic. It's just you're doing everything that either the doctor, your educators have recommended, and you're doing very well and continue to do that. But it's like someone that has hypertension, you take medication for hypertension because your blood pressure is normal. It doesn't mean you're not hypertensive. You're still taking medication. So with diabetes, even if you're not on medication, the simple fact that your A1C is within normal range, it does not mean that you're not a diabetic. Pre-diabetes is more reversible, but once you're a type 2 or a type 1, there's no going back. Basically, it's managing it. I mean, if anybody else wants to comment on that, I'm like,
To piggyback off of Hilda, there's no cure. You're going to be a diabetic for the rest of your life. Maybe later on they'll figure out a way. But right now it's not curable, right? There's treatments. You can take medication. You can take insulin. You can get your A1C down. You can even have a pancreatic transplant, which I had 2 of, which can basically treat you for a few years. I had 3 or 4 years with my pancreatic transplant, so I didn't have to worry about insulin, but I still was a diabetic. So you could be in what they consider remission, but it's pretty much going to stay with you for the rest of your life.
All right, great. All right, great. So we're coming towards the close of our hour. There's one question here that I'm going to leave for Janine to answer. And the question is, how can I benefit from Diabetes Foundation, a community resource? We'll have Janine address that. So I'm going to get back and thank all the panelists again for answering all their questions, for their great presentations. So before I call Janine Salenti back for a final farewell, I'd like to share the results of our poll today. So Ben, if you can put up the poll results for our audience so they can take a look. Okay, so the first question was true or false, sugar is a carbohydrate, and 93% of the people said true, and it is true. Sugar is a carbohydrate, so very good. And can we have the second one? Okay, so the second question was, according to American Diabetes Association, the Association of Diabetes Care and Educational Specialists, there are how many care tools involved in comprehensive diabetes management? A couple of different answers, but actually most of the participants got it correct. It was actually 7, okay? And those 7 are healthy eating, being active, medication management, monitoring, reducing risk, problem solving, and healthy coping. All right, great. So everyone did pretty well with the polling. That's great. Okay.
And there was one question that we didn't get to.
Sure.
It was about which test it confirms if you have type 1 or type 2. And that should be a C-peptide test in your blood. C-peptide is another thing that's produced by the pancreas, but it stays in your blood a little longer. So when they test for it, they can see whether or not you are making it. If you don't have any, that's an indication you're not making any insulin, type 1 diabetes, like what I have and what Chris has. And if you have C-peptide, it's likely type 2. Sorry.
Hi, Brian. Thanks. All right, great. So we're close to the end of our time for tonight. So I would like to ask Janine Salenti from our Diabetes Foundation to offer some farewell remarks and to thank again all our panelists.
So much, Dr. Gani. Thank you. Thank you, Hilda. Thank you, Brian. Thank you, Chris. Thank you to everyone who asked questions and everyone who participated tonight. I wanted to, before I close the session, I did want to address Jackson's question about how can you benefit from the Diabetes Foundation as a community resource. So the Diabetes Foundation is a 31-year-old organization. We work throughout the state of New Jersey. You do not need insurance at all. Actually, most of the people we serve are uninsured or underinsured. We have four major programs, and I just want to highlight them at a very high level here. We have what we call diabetes solution specialists on staff, and they're basically patient navigators. So if you need help creating your healthcare team, like all of our panelists were talking about earlier, our solution specialists can help you. If you need to find that endocrinologist, if you need to find a place to get an A1C screening, figure out how to lower your medication costs or lower your monitoring supply costs, we can help you do that. In addition, we have education programs. We are running a diabetes self-management education and support program. We're certified by the Association of Diabetes Care and Education Specialists to run this. It requires no script, there's no fee, it's virtual, and it covers all of those 7 steps to self-care that Dr. Gani was speaking about earlier. It's a 4-week program, 2 hours each night, and then afterwards, you will be able to speak with our certified diabetes educator who's on staff to answer any specific questions you have about your personal care and to help you create SMART goals that can help you move forward in your journey living with diabetes. In addition to that, we have support programs both for children, youth with type 1. It targets kids or young adults ages 13 to about 20, and it's called Voices of Diabetes, and 18 to 23-year-old young adults and adults living with type 1 come online, and they have a support group, and they're very candid about topics related to diabetes, and we encourage children and young adults to get into that program. We also have a support program called From My Living Room. It's for adults living with type 1 and type 2. And our very own Marlene Korngold, who's on our staff, is the host of that. She is also living with type 1 diabetes. And the last program that we have that really identifies what the organization is, and our organization was created based on these programs, was our financial assistance program. So if you cannot afford your insulin, we have a 2-month free insulin program. If you're unable to afford it, it's an emergency, you can come to us for help. In addition to that, we have a monitoring supply program that will offer you 2 months of free supplies. We offer CGMs as well as test strips, Omnipods. We have a free transportation program if you're struggling to go to the doctor, you can't drive or you don't have transportation, or to an A1C screening. We have camperships for children to go to Camp Najada for 1 week, 2-week family camp, whatever you and your family decide that you want to partake in. And lastly, we have an A1C screening program. You can go to a local BioReference. BioReference is our partner, and you can go to one of their laboratories and get a free A1C screening. So those are all the different ways that you could get care through the Diabetes Foundation. And if you want to get involved, just please call us. Visit our website, www.diabetesfoundationinc.org. Call us 201-444-0337. And we have a chat feature online and all different ways to get involved. So please, we look forward to speaking to you. So again, just on behalf of the Diabetes Foundation, thank you, Dr. Gani. Thank you, Hilda, Brian, Chris, for being involved today. Everything you said was so insightful, and we really appreciate you for providing this important information to our participants today. As I mentioned earlier, our Diabetes Care Month is a series of 4 sessions, and today was the 3rd session. There is one more left, and it's next week, next Wednesday at 5:00 p.m., and it's all about finding affordable diabetes care. So different experts will be on that panel, helping to guide you to lower your cost of your diabetes care and find affordable resources in your local neighborhoods. If you missed out on other programs, link to the recordings of the sessions are available on our diabetes website or our YouTube channel. And thank you again, everyone, for coming. And we really, really hope that you're able to join us again next week. Thank you and have a good evening.
Thank you, Janine.
Thank
Thank you,
you.
Dr. Gani.
Welcome. Thank you, everyone.
Thank you.